Welcome to this AHSN network session at the HSR UK 2020 conference with an update on the research and innovation infrastructure in England. My name is Gary Ford. I am Chief Executive of the Oxford AHSN and Vice Chair of the AHSN network, and I will be chairing this virtual session. We've had over 300 participants from academia, industry, the NHS and international colleagues who have signed up for this session. Next slide. We have 4 short presentations. Each of my co-speakers will introduce themselves before their talk. Please submit your questions using the chat function in Zoom. And we will have a Q&A panel discussion for around 30 minutes at the end of the 4 presentations, addressing as many of the questions submitted before and during this session as we're able to pick up. And we'll go into my presentation. I'm going to give a short overview of the Research and Innovation Needs Survey the AHSN network conducted last year, covering the implications for innovators and researchers. Next slide, please. So why was a survey needed? There have been previous reports on future research needs, and more recent one was the NIHR Commission report undertaken by RAND on the future of health and healthcare in England, which was predominantly views of the research community and was taking a 20-25 year long-term perspective. The other reason a survey is needed is the NHS has been poor at articulating solutions it seeks from the research and innovator communities. And we still have a predominantly push model of innovation where innovators in the research and industry communities develop innovation. They see a value to patients and then seek to persuade the NHS to adopt it. Next slide. The background to the survey was a joint paper from NIHR and NHS England in 2017, where 12 actions were jointly agreed. And one of these was to articulate more clearly the NHS's national and local research priorities. And the commitment was that the 15 academic health science networks in England, on behalf of their local sustainability and transformation partnerships, now integrated care systems, would work up and set out a statement of local NHS research and innovation needs. Next slide. So we agreed to do this as a coordinated effort across the 15 academic health science networks. We commissioned ComRes to undertake qualitative interviews and a quantitative survey in each AHSN and applied research collaboration region. We very much focused on the views of clinicians and managers in the NHS rather than researchers, and we were interested in short to medium term rather than long-term priorities. Our aim was to have 5 in-depth qualitative interviews in each AHSN, and we achieved that in most AHSN regions, and to have 40 completed surveys in each region where we obtained about half of our aim. Our overall response rate was 21%, which is reasonable considering we were approaching people with generally very heavy clinical and managerial commitments. The outputs were 1 national report summarising findings and 15 regional reports, which are available on local AHSN websites, and 15 statements of local research and innovation needs, which have been published on each AHSN's website. Next slide. So what were the key findings? Well, there were some differences in regional priorities, but the themes that emerged were common across the 15. And the 4 key priorities were solutions to address workforce challenges, research and innovation that help deliver mental health services, especially in children, integrating care for older patients with frailty, complex needs and multimorbidity, and helping the NHS use digital and AI technology effectively. None of these are surprising, but perhaps the emphasis on workforce is something that wouldn't be normally a major focus of researchers. Next slide. So was there local variation? With the sample size we had from each AHSN region, we have to be cautious in our conclusions. And as I mentioned before, findings were largely similar, but we did see evidence of different emphasis in individual AHSNs. And I quote some of the examples there. In my own AHSN, there was a focus on improving quality and efficiency and solutions for obesity. In South London, which has a younger population, more focus on BAMA issues and social isolation. And in Manchester, concern on solutions for people from lower income backgrounds and young people. And in Yorkshire and Humber, more emphasis on respiratory disease, consistent with the northern regions having a greater burden of respiratory disease. Next slide. So, in summary, what do we draw from the survey? Well, we achieved a wide range of stakeholder engagement. We unfortunately did not have a timescale we could effectively engage patients and the public, and we are taking that forward in future workshops across the applied research collaboratives and AHSNs. All regions could highlight work relevant to the priority areas, and there was a lot of existing work in mental health, and the research community has had a lot of emphasis on multimorbidity in the last couple of years. We are taking forward further discussions and workshops to drill down into the detail of these broad priorities, and you'll hear in some of the future presentations in this session some of the plans for collaboration across the AHSNs and AHSCS, which will address some of these areas. Overall, I think it's important to observe that in asking non-researchers to talk about research and innovation priorities, it's not straightforward. We took a focus of asking people what they thought their problems were they were looking for solutions for, rather than asking them for a research question, and I think that was a better approach. We see this very much as the start of a conversation and discussion, and critical that we do engage patients and the public in that discussion. And I suppose the major conclusion would be the need to have a much greater focus on workforce and workforce productivity, which is perhaps a shift that researchers and innovators could think about. And finally, local context is important, but we mustn't miss the opportunities for national learning and collaboration. In the context of the pandemic, I think it is interesting that the 4 priorities remain important. Workforce has become even more of an emphasis. Mental health is a major concern in terms of the future mental health needs of the population from the impact of the pandemic. And digital and AI solutions have really been explored in the context of the pandemic. And of course, the people who have mostly suffered from the pandemic are the elderly with multimorbidity. I'll now pass over to Eileen for her talk.
Hello, my name is Eileen Taylor and I'm a Professor of Public Health and Primary Care Research at Newcastle University. I'm also the Director of the new Applied Research Collaboration for the North East and North Cumbria. And I'm going to talk now a little bit about how the new AHSCS fit into the research and innovation landscape. I'll begin with some general context about the AHSCS and then move on to the National Priorities Programme of Work for the AHSCS. Next slide. So there are now 15 AHSCS in England, that's 1 per region, and they were designated in October 2019 for 5 years. They replaced the old CLARCs, or Collaborations for Leadership in Applied Health Research and Care. Their funding is £9 million for a 5-year period of time, and there's also a considerable degree of match funding from the local health and care system. Some things remain similar for the AHSCS in the sense that there is this requirement to have partnerships with members of the local NHS, and the match funding element is the same. Nevertheless, the new AHSCS have got a stronger focus on multi-university partnerships, and there are 6 universities linked in my AHSCS, and also in developing new relationships, particularly with partners in social care and public health. So we're really trying to have a new focus on local authorities within each of the 15 regions. Next slide, please. So the AHSNs themselves, their USP is essentially to drive forward pragmatic research and evaluation that can inform implementation. And there's a very specific focus on the priorities of the region. AHSNs are generally about partnership and collaboration, and they're trying to link up all parts of the health and wider care system, and also all the existing networks and infrastructures in each of our regions. The AHSNs have a remit to build capacity and to develop capability, but essentially we are very much about mobilising evidence to support implementations, and also about engaging and involving members of the public in all of our work. Next slide, please. So on this slide, I've just essentially shown you the regional priorities for my local area. And we drew these up after conversations with over 300 stakeholders across the region. And there are some issues that each region feels is a specific priority for them. And in the North East and North Cumbria, inequalities came very much to the fore, and so too did prevention. Nevertheless, if you look at all the AHSNs across England, there are issues in common for all of us. And I think this touches on what Gary was saying about the RAND review. And so there are issues to do with mental health, for complexity and multimorbidity, and integrating data, which are issues in common across all parts of England. Next slide, please. So a key strength for the AHSN, though, is our very, very wide cross-sector membership. In my own AHSN, we've got a roughly 50-50 membership between people who live and work in universities, the research and academic part of the AHSN, but we've also got partners from the NHS, from public health, social care, the voluntary and community sector, and also members of industry. Perhaps the industry representation is less for the AHSN compared to some other infrastructures in England. Nevertheless, this is where our strong commitment to partnership working with the AHSNs comes into place, because there are very well developed relationships in that particular sphere. Next slide, please. So where does the national priorities issue come into the AHSN landscape, where we are very much regional sort of structures? Well, as I mentioned, there are issues that occur and reoccur across different regions of England. And it is important for NIHR to be able to identify a pool of experts who can bring their knowledge to bear on specific topics, but also people who are keen to work together on challenges that reoccur across the country. And one issue that has been described in a number of regions is that of coastal towns, and whether the coastal towns are in the northwest or the northeast, or down in Thurrock or in Portsmouth, there are challenges that these places all experience to do with urban decline and the loss of some of the kind of to do with essentially the decline in some of our seaside towns. And it's really important to bring together all the talents, all the brains and all the skills that we have across England to tackle these difficult and reoccurring problems. And the COVID pandemic has very much brought this to the fore in the last few months. And it's been recognised that system change needs collaboration at a strategic level. We need the AHSNs to work together, and the AHSNs to work together in close partnership with the AHSNs and other parts of the innovation landscape. As AHSN directors, we know that our partners have the resources for change. They have the levers that can enact change in local areas. And the AHSNs, we have the methodological and evaluation skills to essentially mobilise the knowledge that we have to inform implementation, and then to evaluate what changes do and do not work in our local areas and also across the regions. Next slide, please. So NIHR has gone through a process of trying to identify what are its national priorities, and it has articulated 8 national priority areas, and there was a call for funding to each of these 8 areas in November 2019. The outcomes of the national priorities call have been announced, and 7 out of the 8 priority areas were funded. What you can see on this slide are the AHSNs that are taking a lead on each of these national priority areas, and how many other AHSNs have come together into a consortium to work together to address these priorities over the next 2 to 3 years. You can see that all 15 of the AHSNs are involved in work around mental health, including children and young people. And 9 out of 15 AHSCs are involved in the consortium, which is focused on adult social care and social work. And I think this probably just represents a situation where there is less academic research capacity in social care at the current time. Next slide, please. So how will these consortia operate? So when you look at the plans for all the successful consortium bids, they've all got a very, very similar commitment to partnership work and co-production. There are plans to identify stakeholders and partners within regions and also across regions to come together to prioritise 3 to 4 areas of work that they want to work on together, and to build a consensus about how to go forward to address some of the key challenges in the 7 funded areas. As I've said, the AHSCs through the NIHR funding are able to bring the research and evaluation skills, and we're able to access the evidence base that is already there to inform implementation. And it is our partners who have the resources to actually ensure that the changes happen across the local health and care system. They've got the leverage and they've got the scale to do that, and we're going to work together to evaluate the innovations and the changes so that we can try to achieve impact on a wide footprint right across England. Thank you.
Thanks, Eileen. So we've heard about AHSCs. Now we're going to hear about academic health science networks and academic health science centres. My name's Mike Roberts, and I'm the Managing Director of UCL Partners, which contains both an N and a C. So what's the difference between the two, and how can they work together? Next slide, please. The AHSNs were first established in 2011 as a national but regionally based network. There are 15 altogether, covering the whole of England, but not the other home countries. They work collaboratively together as a network to negotiate commissions with NHS England, Improvement and the Office for Life Science, and to influence policy, but otherwise work on a regional basis, sometimes collaborating across AHSNs, to bring together the NHS with the care sector, with industry, universities, and the third sector to achieve change in the system that couldn't be achieved working alone. Next slide, please. The mission is clear: to find, develop and support healthcare innovation with 3 key aims: improving lives, saving money and driving economic growth. Next slide, please. AHSNs have both local mandates and national ones. The real strong point of the AHSNs is, however, their local partnership working. Understanding exactly what is going on in the system, what the challenges and needs are, and then bringing together these various bodies to work collaboratively to solve problems and make changes happen in a way that couldn't be the case if academia or the NHS or social care was trying to address these issues on their own. And in that process, identifying local innovation and change, which can be nurtured, can be assessed and evaluated, and then scaled up across the region or beyond. Next slide, please. There are a number of national programmes in addition to those regional programmes, which the AHSNs deliver across each and every one of the 15 regions. And whilst there are a number of these, I want to categorise these into 3 main areas. The first is adoption and spread of programmes. As I mentioned earlier, each AHSN and region will identify innovations within that region. They will then evaluate them, and there is a process on an annual basis where they are considered for national adoption against those KPIs that I mentioned earlier on. A small number of those programmes are agreed to be commissioned by NHS England Improvement to be spread across the whole of the country. And there's a wide range of these. For example, the use of magnesium sulfate injections in premature labour to reduce the risk of cerebral palsy in premature infants, ranging to the adoption and implementation of software programs into primary care systems that reduce the risk of medication prescribing errors. The second big area is in innovation exchange. And the AHSNs employ teams of people who work as brokers and facilitators who move between the NHS and the care sector, identifying challenges that require innovative solutions, and linking those in then with academia, the universities, and industry to try to help come together to work out how those challenges might be solved. In some cases, it's, as Gary has said earlier, it may be that the industry or academia has come up with a solution, and then the AHSN team will try and work with the NHS to see whether that's suitable and how it can be adopted and spread. And finally, there may be local innovations at NHS level which require nurturing and introduction to academia and to industry in order to help them grow and to spread them outside. The third category is in patient safety, and once again there's a whole range of interventions here that the AHSN network deliver through the National Patient Safety Collaborative, which is commissioned through NHS Improvement. But an example of this might well be that cited for the National Laparotomy Collaborative. In the past, there's been a lot of concern about variable outcomes for patients undergoing emergency exploratory surgery, simply because of the variation in the processes and procedures used across individual organizations. So developing a care bundle that standardizes the approach has now been adopted, and the collaborative has made sure that all hospitals across England use that same standard approach, reducing variation and saving lives. So a whole range of different functions that are offered by the AHSNs, either regionally or across the whole of the country. Next slide, please. The academic health science centres are rather different. They were first established in 2006 and were the brainchild of Aradazi, building on similar concepts that had been used in the United States, Australia, and other parts of the world. In essence, the idea was to speed the translation of discovery science into clinical practice for patient benefit by forming alliances between a small number of really top universities and top NHS organizations. So these relationships tend to be much more localized than the AHSN, so one university or sometimes two or three working together in a collaboration with one or two NHS organizations. They don't have the same coverage across the whole of England. They're just the 8 AHCs at the moment. And there's been a new relicensing process which was completed in April of this year, which provided for the addition of 2 new AHSCs, Bristol and Newcastle. And the other change that's happened in the AHSC structure has been greater involvement of NHS England and improvement in planning the framework for the delivery of the AHSCs. In the past, that was pretty much down to the NIHR, but now the AHSCs also have to support the life science industrial strategy and the goals of the Accelerated Access Collaborative, which we're going to hear about in the next presentation. Next slide, please. So this might all add up to be a rather confusing landscape, and sometimes it can help to try and see how this might all fit together by using a more tangible concept. And on this slide, I want to suggest to you that this is all around an innovation pipeline. So how do we go from discovery of new things, whether that's devices, drugs, whether that's new pathways, to their evaluation and then adoption and spread within the NHS and care sector in quick time to improve benefits to patients. And if we were to look at that pipeline from left to right, discovery to spread, the academic health science centres are firmly on that left side, and the discovery science and the evaluation spectrum. There's no direct funding from the NHS or NIHR to the HSCs, but it's rather like a badge of honour, and it helps them to attract better research scientists and to go out and bid for better funding contracts. The NHS ENI and the AAC have directed the academic health science centres to particularly concentrate on advanced therapy medicinal products, artificial intelligence, and histology-independent treatments for cancer. At the other end of this pipeline, we've got the AHSNs, whose forte is in adoption and spread, with the relationship building with the NHS and with industry and third sector and care systems. So an example of how the collaboration between the HSC and HSN might work and has worked and should work in the future is around the drug cladribine. And this was a drug where a lot of the research was carried out through the AHSC system, which identified that this drug had a place in the management of relapsing multiple sclerosis. Having done that, a contract was then awarded through NHS E and I to the Academic Health Science Network to use their relationships with regions and across the country to ensure that that drug was incorporated into routine clinical practice to the benefit of patients. And that happened within a matter of a number of months, as opposed to the historical time period of some years between discovery science and implementation. So that's an example of how the AHSCs and the HSNs could work and should work. I think it's going to be up to us to make sure that that is the norm for the future. So I'm going to hand over now to Zoe. Thank you.
Hello everybody, my name is Zoe Lelliot and I'm the Chief Exec of the Health Innovation Network, which is the AHSN for South London. So you've heard from both Mike and Eileen about some of the different regional structures in the research and innovation landscape. So the AHSCS, the AHSCs and the AHSNs. Now I'm going to give you a very brief overview of the national innovation landscape and specifically the Accelerated Access Collaborative. Next slide, please. So what's the problem we're trying to solve? Historically, innovation has been much like research in that there's no shortage of high value innovation in the NHS, but which may be generated by either clinical innovators or by commercial innovators. The issue is with the time it takes to get that innovation to reach routine clinical practice, which, as Mike said, may be years, if in some cases at all. And there are multiple reasons which contribute to this delay. The complexity of the NHS, the number of organisations involved in innovation, and also the lack of support for innovators to help them to develop their ideas. Next slide, please. Therefore, in this context, there seemed to be a real need for a review of the innovation landscape. And this happened with the Accelerated Access Review, which was published in 2016 with a series of recommendations. So the key aim of the review was to speed up access to innovative drugs, devices, diagnostics, and digital products for NHS patients. And this report led to significant changes in the innovation landscape through the creation of the AAC. It's also seen a substantial investment in infrastructure around innovation for the first time in this country, which has created the innovation architecture which we have today. Next slide, please. So what's really changed with the Accelerated Access Collaborative? Firstly, the AAC has engaged all the significant partners at a national level who are involved in innovation, including NHS England, the trade bodies, so industry, regulatory bodies, the AHSN network, the NIHR, as well as patients and patient representatives. All parties are brought together to tackle the challenges around innovation and the barriers as part of what is a real partnership. Next slide, please. So this is the innovation pipeline that was described by Mike earlier. And the AAC also operates along the full length of the innovation pipeline, from supporting development of very early stage ideas through to supporting the adoption of mature and well-evidenced products. And it works in partnership with the relevant bodies at every stage of the pipeline. So for example, at the early ideas development stage, it works with the academic health science centres, and it works with the AHSNs at the late stage for spread and adoption of mature products. Next slide, please. So this slide illustrates some of the key functions of the AAC. So a single front door enables innovators to easily access the support that they need and to access the NHS. Demand signalling helps to understand the needs of the health and care system and also to allow innovators to respond to those needs. Horizon scanning provides a joined-up approach to identifying emerging innovation at the beginning of the pipeline so that the NHS can prepare for this when that becomes adopted. Testing infrastructure is important to allow innovators to provide evidence of the impact of their innovations, and adoption and spread supports the scaling of innovation. And finally, a funding strategy which enables government, charities and research organisations to have a joined-up approach to funding of innovation and also the provision of incentives to support the adoption. Next slide, please. So just to illustrate in a bit more detail, I'm going to focus on one element of the AAC, which is the Rapid Uptake Products, or the RUPs. These have been selected through a rigorous national process as being innovative, but also as being able to deliver high value to the NHS, and that's both in terms of patient benefit, but also in terms of cost savings. So examples of the rapid uptake products include high sensitivity troponin, which enables the early rule out of a heart attack, and also Urolift, which enables a less invasive prostate operation, reducing hospital stays. But in order for health systems to adopt these innovations successfully, there will need to be a number of changes required to clinical pathways. Therefore, the AAC has partnered with the AHSNs, who are able to help by providing on-the-ground clinical champions and project managers who facilitate the process of pathway change and thereby adoption of innovation. So in summary, we now have a much more comprehensive innovation architecture at the national level, characterised by really strong collaborations, which gives us the prospect of speeding up the innovation pipeline in the future. Thank you.
So we'll now start the Q&A discussion for the next 20 minutes or so. Unfortunately, Eileen's unable to join us for this, so the three of us, Mike, myself and Zoe, will answer questions as they're submitted. I'll pull them out of what is coming in and ones we've had before. First question for you, Mike, is how do we combine evidence of effectiveness, feasibility and acceptability with the wisdom of clinicians who are adapting interventions to respond to the constraints of context and the symptoms, comorbidities, needs, preferences and circumstances of the patient in front of them? So the whole issue of adaptability.
Thanks, Gary. I won't ask you to repeat that question because that will take all 20 minutes, I would think. I'd like to break it down, though, if I may, into two elements. So one is the one you referred to at the end, which is about local adaptation of innovation, or for that matter, research findings, to meet the local circumstances. And I think that's absolutely an essential part of any implementation and spread program. You can't be too rigid. There has to be an ability for local teams to adapt that innovation to the local circumstances. So I think giving permission for that to happen and making it clear that you don't have to stick rigidly to every single element of the innovation is important. However, there are usually some key elements of fidelity that need to be maintained. Otherwise, it's unlikely that innovation, if applied outside of the context in which it was designed, is going to be so effective. I mean, the second part of that question, as I read it, was there was a huge amount of experience there from clinicians, managers, others for that matter, on the ground, and how do we capture that as well? And part of that is in how they implement change, but part of that also is how clinicians themselves pull together innovative ideas and thoughts, and how do we capture that? I think there's a good example of that, which came out through the COVID crisis in the London Nightingale, where we were involved with the NHS Trust who set that up, which was Barts Health, in setting up a learning health system there. So one of the things that was done was to train up a group of people who were mainly actually master's students from some of our local universities who were unemployed during the COVID period for obvious reasons, and they were trained to become what we called bedside learning coordinators. So their job was to go around on the shop floor and pull out clinical experience and learning in real time, and then try and pull that together into a number of very short and brief but clear messages, and then carry that around the organisation so that people learnt in real time, and then to use the research evidence that was coming through at a slower pace to try and validate some of those clinical findings, but also to use those clinical experiences to inform some of the research strategy that was going forward too. So two different elements to that question, I think, and hopefully two helpful answers.
Yeah, thanks. I think that covers some of the key aspects of considering adoption of innovation. Zoe, we've got a question on incorporating experiences of mental health service users both into research design and delivery of services based on the research findings. I mean, we've done, as AHSNs, a number of mental health programs. Perhaps you could comment on this issue of user involvement.
Absolutely. So the AHSNs, AHSNs and AHSCs all take user involvement seriously, not just in mental health programs, but in all the programs that we do. And that's partly because it leads to better outcomes, but also because, of course, it is an expectation now of our major funders, so NHS England and NIHR. So to illustrate how this is done, I might take an example from our current national programs. So there was some research that was conducted in the Academic Health Science Centre, King's Health Partners in South London, which was around the early intervention in eating disorders, which led to significantly improved outcomes. So based on the strength of that research and the evidence around the new model of care, we selected that as a national programme for the AHSNs to support the implementation. So in the research design phase, the Mental Health Trust there involved both service users from their eating disorder service, but also worked with third sector groups, so a charity called BEAT, who's active in eating disorders, to make sure that those patients and individuals with eating disorders were actually able to shape the model that came out of the research and was demonstrated to be effective. The AHSN network have taken that research and we've been planning to roll that out nationwide. So we've done that by creating a steering group, and that steering group again has had service user involvement, and we have been working with the team in the South London and Maudsley who came up with the research actually to tap into their service user networks. So that's just one of the ways that illustrates how we are involving the service users both in the design of the research and in the implementation.
Yeah, and I think one of the things we're looking at as an AHSN network is our overall strategy and approach to patient involvement in our work and linking that in with user involvement in the research infrastructure. We have a question, there's a few questions about AAC. This is a question that came in advance. What criteria of products or services trigger clinical outcomes and financial value judgments for programs like the AAC? So I'll comment just on the AAC, and then which has very specific criteria in terms of the selection of a product as a rapid uptake product, and would emphasize that there are only a few of those products. I mean, we're looking at 6 potentially going forward in the next year. So for the AAC, first of all, any product has to have a nice review and positive recommendation. The second issue, which not sure everyone's aware of, is they have to have a high quality gain per treatment, person treated. That was 2 QALYs, which is a pretty high bar actually, but is now with the AAC are looking at anything above 1 QALY gain. But just to put that into context, the typical QALY gain for a new drug coming to NICE might only be 0.1 QALY, for example. And then there is the issue of the affordability financial impact on the NHS, although I don't think that's been a major issue to date. But the AAC rapid uptake products are very driven by what NICE has reviewed. So if NICE has not reviewed it and done a health economic analysis, they don't really come into the frame. I think what criteria we consider for for the AHSN network is somewhat different. Zoe chairs the National Programme Development Group, so I don't know if you want to comment on the issues that we consider in terms of what we adopt as a service model or product as a national programme for the AHSN network.
So there are a number of things, I suppose. Obviously the strength of evidence, the scale of impact. I think measurability is absolutely critical, so we can demonstrate the outcomes, outcomes that are important to patients. I'm sure there are many other besides, Gary, but that's off the top of my head.
Yeah, I think we would want to see significant impact to the population health level generally, and opportunity where possible to work in workforce productivity or NHS savings through pathway redesign. Quite a few questions about which people can see in the chat, about the different infrastructure. So let's start with one. Where do you see the AHRQs sitting on the innovation pipeline compared to the AHSNs, AHSCs and AACs, and how can that be linked effectively together? The three of us are actually the implementation leads for our AHRQs, so I think we can all sort of speak to that, but maybe I'll ask in the first instance Mike to comment on that. I think it's fairly easy. There's an interesting discussion about how do AHSCs fit in. Interesting comment from Maxine Cliff that the AHSCs are the umbrella for AHSN's AHRQs and other infrastructure within their regions. That's interesting perspective, because actually we wouldn't see that being the case at all. The AHSC is a much smaller group of partners within the region, the AHSN region, and in fact the language of the Commission for AHSCs was AHSCs are nested within an AHSN. That's not to say the AHSN is responsible for overseeing the AHSC, far from it. But it may be in some areas the AHSC is chosen to be the umbrella infrastructure, but I think that is not the case for certainly our AHSC or the ones I'm familiar with. And Mike, do you want to talk about where AHRQs sit on the innovation sort of line between AHSCs and AHSNs? I think it's very obvious to us, but in the proliferation of acronyms, maybe not obvious to many people looking in from outside.
Sure, that's right. And I think things have become a bit clearer in the sense that there's now a greater regional alignment between AHRQs and AHSNs, whereas as Gary's pointed out, AHSCs, there are 8 of them and there are 15 AHSNs, so there isn't quite the same co-location there. There used to be 13 clerks, which were the predecessors of the AHRQs. Now there's 15 co-located with the AHSN, so the relationship's a bit clearer there. But in essence, the AHRQs are what they say on the tin, which is about applied research, and that's rather different from the AHSCs, which are more further up the line in terms of the discovery science. And there's probably a greater natural affinity, I would argue, between the AHSNs and the AHRQs than there is between the AHSCs and the AHSNs. But ultimately, if you see part of the purpose of the AHSN to be the delivery partner of innovation, research, discovery, whether it's applied or discovery science, then there is an obvious relationship between both the AHRQs and the AHSCs there, in the terms of scaling up and implementing the findings where relevant into the health and care system. On the diagram I put there, I try to articulate that relationship. So if you think again about this innovation pipeline, on the left-hand side, we've got discovery science, on the right-hand side, we've got adoption and spread, and then in the middle, we've got evaluation. And the AHSCs do some evaluation, and they will also do a little bit of adoption and spread, but it's like a wedge, more on the discovery science, much less on the adoption and spread. The AHRQs are in the middle there, doing mainly evaluation, but applied health research evaluation rather than sort of laboratory science, in that, if I could put it in that crude sense, and then working to implement their work through both the implementation leadership within the AHRQs, and we've said that we 3 are all implementation leads, but also collaborating with our AHSNs to use their networks to get the discovery science implemented into practice.
Yeah, thanks, Mike. I think one of the positive things we've seen in the last few years is, first of all, more collaboration between individual elements of the same infrastructure. So we see a lot more collaboration between the AHSNs Eileen highlighted the collaboration between the AHSCS, which I think there's a lot more, and there's a more formalised framework for it. And then also we've developed a lot of joint working at a national level between the 15 AHSNs and the clerks and AHSCS, and we now meet at least once a year, the directors of each, to discuss that. And we have also had one meeting of the AHSCs and AHSNs to look at how they will work together, and the AHSCs are thinking how they will work collaboratively. And I think that has been quite a useful process in terms of defining priorities and areas where collaboration would add value. Got a question which I think is, I think really interesting to any of us who've been, dealing with this problem of how do we get more rapid change, innovation. And the COVID crisis seems to have speeded up many innovation processes. Is a review plan to look at what we can learn from this? We could all sort of start with a comment on this. I mean, certainly some innovation, particularly in the digital space, we've been able to get implemented much more rapidly. So, for example, across the Southeast region, so this covers 3 AHSN regions, we're leading an evaluation of the rollout of stroke AI imaging software and workforce support package to speed up delivery of thrombectomy. We've seen the implementation of these go at a pace that is just far quicker than we were seeing for the last 2 or 3 years. So I think we have seen a lot of things speed up. I mean, maybe ask each of you to give a perspective, first of all, on what's happened, but secondly, who's going to review and to capture the learnings from this? Zoe, do you want to make a start?
Yes, so I think this is something that's being discussed all across the country, and I think all the AHSNs are variously being involved with their local regions who are looking at the recovery planning phase. And certainly we're aware locally that there's been a massive amount, for example, on digital remote consultations, and whereas some of that is very positive, I think there are concerns that there may be unintended consequences of that or significant impacts on health inequalities. So we're working across London, that's the 3 AHSCs